Good evening, everyone, and welcome
Recording in progress.
again in Bounce Back webinar series 3. Nice to see all of you here. Today's topic is failed back surgery syndrome, challenges versus solutions. So at the outset, I would like to welcome all our faculty members, Dr. Ram Chadha sir, Dr. Samir Uparel, Dr. Shreel Koirala, Dr. Ankit Patel, and Dr. Saijot Raut, and also all our delegates, who have been coming back to this very interesting webinar series, Bounce Back, which is talking about different aspects of the spine. So before we go, we will have a very detailed introduction, of course, of all our faculty members. But before that, I will just take a minute to introduce our company, Integrace. Next slide, please. So we are one of the youngest amongst the top 100 pharmaceutical companies. We were established in 2018, and since then we have been trying to establish ourselves, in this field by various academic oriented programs. Can I have the next slide, please? So we have, our leadership in the two therapy areas, namely sulostazole and pregabalin, nortriptyline, mecobalamin combination. And, we are, as of now, trusted by more than 32,000 Indian doctors, which is really a matter of pride for us that, so many doctors actually have trust on us and our products. And we maintain a very robust distribution system to ensure that our products which are prescribed by our doctors reach out to the patients across the length and the breadth of the country. So those are a couple of salient points about our company. And as I mentioned, we are driven by values of innovation, impacting life and inspiring others, and therefore we stand committed towards partnering with the orthopedic fraternity. And to that end, we have basically tried to come up with a lot of properties, lot of platforms, which basically further the cause of the academic upliftment for our orthopedic fraternity. The top amongst these is the Best of Orthopedic Technique event, which is I think the second largest orthopedic congregation in India after the IOS annual conference. And we started off with around 1,000 orthopedic surgeons participating. And at the last count, we were somewhere around 3,000 orthopedic participants for this program. And, we partner with the Orthopedic Trauma Association of US and try to bring the latest techniques and technologies, best of the faculty members, both from India and abroad for these kind of programs. In the same series, we also ran, and we are actually one of the first companies to start the Best of Orthopedic Technique Web Academy last year. When the lockdown wave 1 started, immediately we were able to kind of engage with our orthopedic fraternity by providing them the latest know-how and techniques and technologies on orthopedics. So that was another good thing that we were able to achieve in this short span of time. And of course, we have an app called We Connect Health, on which we host all our the scientific programs, the recordings, etc. And I would request all of you, my delegates, to whenever you have time to visit and see all the international and national faculty members recording there. Next slide, please. I'm very honored and happy to share with you that we follow a very good work culture, and therefore at our company we have been recognized as a great place to work certified company. Very few pharmaceutical companies in India, I think 3 or 4 pharmaceutical companies in India have got this achievement, and I would thank all our doctors who have kind of supported us to manage to achieve this. Next one, please. So that was a little bit about Integrace, and now coming to our superstar of the show, our faculty member, Dr. Professor Ram Chadha sir. And I think he does not need any introduction. He is a very, very well known face in the fraternity. Dr. Chadha is a consultant spine surgeon for Lilavati, Jaslok and Global Hospital in Mumbai. He has been a professor and head of the Department of Orthopedics at KG Soumaya Hospital and the Medical College, and has been associated with the academics for a very long time as ex-senior visiting consultant at SAFI, Wokhart, Fortis, Guru Nanak Raheja, Apollo Hospitals, etc. In terms of his association, association with the large bodies of doctors, he has been the past president of Association of Spine Surgeons of India, Bombay Orthopedic Society, Bombay Spine Society. He has been the chief national delegate for APSS and a council member for APOA. Other than that, Dr. Chadha has pioneered the MICOSS, which is the short form for minimally invasive cosmetic spine surgery in India. And he has used the endoscopic spine surgery for the first time in India in 1998. So he is, as a pioneer in the field. And consequently, Dr. Chadha has been, recognized by numerous awards in this field. So J.B. Modi Gold Medal, the Spine Instrumentation Fellowship, the Barrows Neurological Institute Fellowship, and the list goes on and on. And we are really very fortunate, sir, that you are here, as a mentor and a speaker to all of us. So before we proceed with the program, I would request Dr. Ram Chadha sir to share a few words.
Thank you very much, Prashant Mishra ji. Thank you very much, Shekhar. Thank you very much, Meenal ji. It's indeed a proud moment for the five of us who represent the spine team to be here sharing our failures with a lot of you. I must say that failures teach much more than success. And I've strongly believed in what Sir Winston Churchill said many years back, which is success is not final, failure is not fatal. It is the courage to continue that matters. Today, we try and break down failed back surgery syndrome, and to share our failures, we have 4 of the best trained spine surgeons in our country who will try and walk us through this journey of how to handle failed back surgery syndrome. We have Dr. Sameer Ruparel, we have Dr. Ankit Patel, we have Dr. Saijot Raut, and we have Dr. Shreel Koirala. These are my colleagues, as trained, better trained than I am, and I look forward to spending the next 90 minutes with all of you in their company. May I call upon Meenal ji to please introduce my colleagues, and then Dr. Sameer Ruparel to take over the proceedings.
Thank you, sir. On behalf of Science Integra and Integrace, I welcome all the doctors for this amazing series of Bounce Back. And I'm privileged to introduce the rest of the faculty members today. So we have Dr. Sameer Ruparel. He's a consultant spine surgeon from Jaslok Hospital and Glen Eagles Global Hospital, Mumbai. He has done several fellowships like Association of Spine Surgeon of India, Fellowship of Australian Institute of Musculoskeletal Research, Melbourne, Fellowship in Minimally Invasive Spine Surgery, Japan. So I welcome Dr. Sameer Ruparel.
Thank you, madam.
I also welcome Dr. Shreel Koirala. He's a fellow spine surgeon at Leelavati, Jaslok and Global Hospitals, Mumbai. He is an ex-senior resident Department of Orthopedics at Maharishi Valmiki Hospital, Delhi. He has done a post-graduation in MS Orthopedics from Ramaiah, Bangalore. He has a special interest in deformity correction, revision spine surgery, and minimally invasive spine surgery, actively involved in various research work in the field of orthopedics and spine surgery. And he has undergone training through various workshops. Some of them are like on osteointegration from Osteointegration Group of Australia, Advanced Trauma Life Support course organized by ATLS India, and he is a member of ASSI, SICOT, and ASAMI. I welcome Dr. Shreel Koirala. I welcome Dr. Ankit Patel. He's a consultant orthopedic spine surgeon at Sanjeevani, HCG, Astha and Wokhad Hospitals, Mumbai. He specializes in minimally invasive spine surgery, endoscopy, spinal deformity correction, spinal oncology, and pain management. He has an experience of more than 8 years in these fields. He is an author of more than 20 scholarly peer-reviewed papers and chapters in textbooks of spine surgery. He's a winner of Young Surgeon of the Year Award at SMISS Las Vegas, USA, and also Korean CIOT Award in Cape Town. He has served as faculty and fellow at NHS Nottingham Spine Centre, UK, and several other international hospitals and universities. So I welcome Dr. Ankit Patel.
Thank you.
And last but not the least, we also have Dr. Saijot Raut. He's a fellowship. He has done a fellowship in Adult Spine Reconstruction, Mumbai, fellowship in Spine Surgery, Mumbai, fellowship in Scoliosis Research Society, USA, and in Minimally Invasive Spine Surgery, Mumbai. He is a life member of Association of Spine Surgery India, AO Spine, and International Society of Orthopedic Surgery and Traumatology. Also of IOS and National Academy of Medical Sciences and Bombay Orthopedic Society. So I welcome Dr. Saijot Raut. And I request now Dr. Samir Ruparel to please take over the proceedings of this discussion.
Thank you so much, madam. I'll just share my screen. Is my screen visible and I'm audible?
Samir, go
Yes,
ahead.
sir.
Yes, sir. A very good evening to everyone. First of all, I would like to thank Integrates Orthopedics and Science Integra for having us, as well as Ram sir for giving us the opportunity to talk about a very complex topic in spine surgery. And I'm going to talk about causes and evaluation of failed back syndrome. Now, let's start with a case example. This is a 36-year-old gentleman who is an IT professional, comes with excruciating pain in the right lower limb since last 4 months, with a weakness in his right toe and sensations reduced in L5 dermatome and right SLR being positive. And as we see the MRI, there's a perfect clinical radiological correlation over here. There's a prolapsed disc at L4-5, probably causing compression of the L5 nerve root. And he has not received much relief after adequate conservative management for 4 months. And the patient was counseled for surgery. And the patient was successfully operated with a microdiscectomy. As you can see in the picture, that there's a huge disc fragment which was prolapsed, and this is what we got intraoperatively. And the patient was perfectly fine until 3 months later, when the doctor came to us, or when the patient came to us saying, "Doctor, my leg hurts just the way it did just before the surgery." And that is where the topic of failed back syndrome and complications start. So what could have gone wrong? At this moment of time, there are numerous things that comes into the mind of a surgeon. There may be a disc space infection, iatrogenic instability that may have occurred, a nerve root injury, there may be a retained disc fragment or a recurrent disc herniation, an inadequate decompression, or there may be complications of fusion or even arachnoiditis. So there are so many issues that can occur after a surgery in a patient who has been successfully operated. How do we evaluate this patient? And this is what we come towards failed back syndrome. And there are so many questions that come to the surgeon's mind in terms of evaluation and the management of this complex entity. So what is failed back syndrome? It is broadly defined as patients who experience chronic disabling low back pain and or leg pain after spinal surgery. Now, this is a very broad definition, and the definition varies in numerous studies in the literature. As you can see over here, there are 2 studies which I have mentioned. The first one mentioning that lumbar spinal pain of unknown origin, either persisting despite surgical intervention or appearing after surgical intervention for spinal pain originally in the same topographical location. So this paper mentions that the pain should be in the same topographical location and excludes the adjacent segment degeneration. And the second is a more functional definition is when the outcome of lumbar spine surgery does not meet the pre-surgical expectations of the patient and surgeon. So as we know, there's a lot of variation in the literature with regards to the definition of failed back syndrome. So how do we define? Coming to the previous example that I mentioned, if this patient would have come only with back pain post-operatively, will we term this as a failed back syndrome? Similarly, if the patient would have had a recurrent disc herniation, would that be documented as a failed back syndrome? Or if the same patient would have been operated with the posterolateral lumbar interbody fusion and comes later on with an adjacent segment degeneration, will we term this as a failed back syndrome? So as you can see, there's a lot of variation in the definition, and because of which there's a variation in the statistics and the incidence of failed back syndrome in the literature. As you can see, Parker et al. Mentioned that the incidence ranges, there's a wide range of incidence from 5 to 36%. And as you can see, the number of spine surgeries have increased by 170.9% from 1998 to 2008. And so we expect that the number of failed back syndromes would also increase proportionately. And this is what we are going to address quite frequently in our daily practice these days. Now, what about the success rates of a failed back syndrome if a patient has to be operated twice? Based on this study, it mentions that no more than 30, 15, or 5% experience a successful outcome after second, third, or fourth surgeries, respectively. Now, this is very horrifying. But I must say that before we jump to these conclusions that the second surgery may not be successful, it is very much necessary to evaluate the patient of a failed back syndrome very thoroughly. Because insanity is just doing the same thing over and over again and expecting the different results. So we basically have to evaluate based on three main aspects, and that is the temporal factors. With relation to the timeline, did the patient have any relief after the surgery, which can give us few cues as to what may be the cause of his present symptoms. Second is a symptom complex categorization, that the patient is only having an axial pain or a mechanical low back pain, or the pain is radicular or claudicatory. And last but not the least, the mantra to success is a proper clinical radiological correlation. Now, before we evaluate the patient, we need to have a detailed history of the symptoms before the surgery, each and everything, right from how much was the back pain, what was the distribution of the leg pain, when did the leg pain increase or decrease, were it associated with any paresthesias, were there any neurological disturbances or deficit, at the same time ball bladder incontinence, and likewise. And we will have to compare these history and these findings with the improvement or the deterioration of the patient after the surgery to the present day when the patient has come to us probably 3 to 4 months after it. As well as we may have to go through all the imaging which were done before the surgery as well as after the surgery. And last but not the least, each and every details of the operative records need to be before we jump up to any kind of an inference to counsel the patient regarding the further plan. Now, let's come to the temporal factors. The first kind of patient is probably there is no relief after the surgery, and which may be due to an operative error, that is an incorrect diagnosis, a wrong level surgery, or an inadequate decompression. Or the patient may develop a new radicular pain in which it may be due to an intraoperative nerve root injury or because of an incorrect implant placement. Second, the patient had an interval of relief after the surgery and there is a sudden onset of recurrence in which there may be a recurrent disc herniation or a hardware failure, or a gradual onset recurrence which may be due to fibrosis, pseudoarthrosis, or an adjacent level pathology. Now, one of the major things contributing to a failed back surgery, I would suggest is a poor patient selection. So it is very much necessary that the failed back can be prevented with a proper decision which is made by the physician evaluating the patient before the index surgery. Last but not the least, there may be a poor patient selection. As I mentioned, this is more apparent in retrospect, particularly the patients who are involved in litigation or workman's compensation or having an abnormal pain behavior in which there may be an overlay of emotional factors. Now, coming to the surgeon-related issues, as you can see over here, the first is a wrong level surgery. There should be X-rays as well as MRIs which need to be present on the operating table, so that there should be a correlation between this, particularly in patients having a transitional vertebrae, as you can see in this MRI as well as the X-ray. The last mobile segment can easily be mistaken at L4-5. Similarly, there may be patients having a multi-level pathology. There may be prolapsed disc or multiple level lumbar canal stenosis, and it is very much necessary to know what is the cause of the patient's symptom and to address it effectively intraoperatively. Otherwise, the patient may land up into a failed back syndrome. Now, coming to physical examination, the physical examination of the patient must be in total detail. If the neurology is involved, what was the neurology pre-op, immediately after the post-op, and today, and it has to be compared like the other symptomatology. And special attention should be paid to the hips, knees, as well as the distal pulses, which act as spinal masqueraders. Coming to the radiographs, it is very much necessary to have dynamic X-rays in lateral, neutral, flexion as well as extension. This is necessary in patients, even in those in which a simple decompression or a discectomy is done, to rule out any iatrogenic instability which is present in the patient today, or an iatrogenic pars fracture. Similarly, you can see signs of end plate rarefaction, in which may be signs of early discitis post-surgery. And those with implants, it may show any malposition, breakage, or loosening of the implants, or an adjacent segment degeneration. Second, we have to get a radiology in terms of CT as well as MRI. CT will show fine cuts need to be taken with sagittal and coronal reconstructions to assess the fusion status and the position of the implants. Last but not the least, it is necessary to have a contrast MRI because it is a most sensitive investigation to assess the neurological compression at the previously operated site and the adjacent levels. As you can see, there is poor enhancement of the disc, which has recurrently herniated, surrounded by the contrast. This is very effectively seen on a contrast MRI as compared to a normal MRI, as the contrast differentiates between the scar tissue as well as the recurrent disc herniation. So coming back to the algorithm, a patient with a failed back syndrome who comes to us, there is a thorough history taking which is necessary, neurological examination, imaging studies, and psychological evaluation. Imaging studies should include dynamic X-rays, CT, as well as MRI with contrast. And then we come to specific diagnosis. If we find a mechanical cause to the patient's problem, then an appropriate surgery may be put forth to the patient. Or if there is a non-mechanical cause, then medical treatment with rehabilitation is necessary. Non-operative treatment is particularly indicated in non-mechanical causes like epidural scar or arachnoiditis. There may be minor fractures, early discitis, peripheral nerve syndromes, or those with masqueraders, as well as even those patients with recurrent disc or stenosis need a fair degree of conservative trial before venturing onto a revision surgery in these patients. And the goal of non-operative treatment, mind you, should be functional improvement. This is very much important with return to work and pain reduction. Now, coming to the problems that we encounter if we put forward the surgical option to the patient. So, the intraoperative factors that we face are poor landmarks of anatomy. There may be a wrong level, neural injury can happen, increased blood loss, longer surgical time, difficulty in instrumentation, and inadequate bone graft and bone stock. These are the problems that a surgeon faces in a revision spine surgery and should be taken into account before contemplating it preoperatively. Now, if you plan for a surgery, these are the indications which have been mentioned in papers for a revision surgery. The absolute indications being the same, with impairment of gallbladder incontinence, or there is a progressive neurological deficit. And there are relative indications which are usually the same as that of an index surgery, a patient not responding to conservative treatment despite 4 weeks of complete bed rest, or there is pseudoarthrosis or instability over here. And there are two kinds of procedures which need to be undertaken. That is, a repeat decompression is advised. or it may be supplemented with instrumentation. For example, whenever there is instrumentation that needs to be supplemented, we need to probably use larger length and diameter of the screws, augmented with cement augmented screws. There may be need for an extension of the fusion construct or conversion of a previous posterolateral fusion to a transforaminal lumbar interbody fusion to get better results in the revision surgery. Now, coming to the details of the surgery, particularly the recurrent disc herniation and adjacent level pathology, this is what we are going to discuss in the management, as will be taken up by Ram sir. There will be detailed case discussions that we are going to talk about, as well as the review of literature, which will be done by Dr. Saijot Raut. But before concluding, the best treatment is prevention. And it is very much necessary to preserve the segmental stability during the decompression of the index surgery. It is necessary to preserve the adjacent or the superior facet joint that may become injured during instrumentation and putting pedicle screws, as well as preservation of the posterior ligamentous complex. Last but not the least, if there's a right diagnosis in the right patient, along with the right surgery with the right surgeon, it will definitely lead to optimal outcomes. Thank you so much.
Thank you very much, Samir. That was an excellent presentation, a brilliant overview of the next 60 minutes that we are going to be together. I would now request the entire team to open their videos, and we would have Samir now lead us through the rest of the webinar. Samir, it's all yours.
Thank you, sir. So we will invite Dr. Shreel to present his first case.
Good afternoon, everyone. Welcome to the Bounce Back webinar series. I'll be talking about a failed back syndrome case discussion. We have a 51-year-old lady who is slightly obese, complains of radiating pain to the right lower limb since 2 weeks. On examination, her leg pain was much more than her back pain, and her activities of daily living was affected. Her SLR on the right side was positive at 50 degrees, and she was neurologically intact. Now, looking at this history, we could see that there is some kind of pathology which is bothering her, and we wanted to investigate further. We did X-rays of a lumbar spine, both in flexion and extension, but we found that there is no gross abnormalities seen in the X-rays except for loss of normal lumbar lordosis. We went one step further ahead and investigated her with MRIs. We found that she had a disc protrusion at the last mobile segment L5S1, which was more of central and on the right side.
So, Dr. Shreel, do you think there is a perfect clinico-radiological correlation, or are you suspecting some other diagnosis in this patient after getting the X-rays and the MRI done?
So, the clinical examination do correlate with the MRI findings. She has a right radicular symptoms, which and the MRI also shows a right side herniated disc.
Right.
Having explained the diagnosis to the patient and its outcome, we explained to the patient, and the patient opted. We explained to the patient both conservative management and surgery, and having explained all the possible outcomes of each and every verticals, the patient opted for a conservative plan of treatment. Patient, over a period of 4 weeks, improved symptomatically and was now able to manage activities of a daily living. After 4 weeks, the patient again comes to the outpatient department, this time again with a recurrence of right lower limb pain. She says that it was exactly the same pain which she had 1 month ago. Her right SLR was positive. She had a S1 decreased sensation on the right side than on the left side, and this time there was a motor deficit. Her right FHL FDL was slightly weak, and her right ankle eversion got weaker.
So Dr. Sai, what do you think? What would have happened if you think about that the patient had previously come to us with the similar symptoms, except that at that time the patient didn't have hypoesthesia, patient didn't have any weakness, but this time the patient is having weakness as well as hypoesthesia. We know that the patient is having probably a conservatively treated right-sided central alpha S1 disc. But do you expect significant change or any change in the radiology? Would you advise a new radiology, or we will continue with the same conservative management this time?
So as Dr. Shreel mentioned about the history of the patient, and as we went ahead with an MRI, I was quite happy with the clinico-radiological correlation. I was also happy with the conservative trial which we had given for the patient. And I think it was the right thing to do. But after this, now after post 3 weeks, when the patient has come to us with recurrent right lower limb pain, I suspect that the disc must have increased in size, or maybe it is that I am suspecting the same disc only. And for now, the neurology patient has have a neurology also now this time. So now we should be aggressive with this and go ahead with the investigation. The right choice of investigation, I think, should be an MRI at this stage. We should repeat an MRI and go aggressively about this time.
Okay, so basically there is a significant change in the symptomatology. We should go aggressively and we should get a fresh MRI done.
Correct.
So Dr. Shreel, did we get a fresh MRI done, or we continued with the conservative treatment?
Yes, no. Because the neurology there was a neurological problem now. The motor was being affected. We did get a repeat MRI done. We investigated her and a repeat MRI was done. The repeat MRI now showed that there was an increase in the disc and the disc had migrated superiorly.
Right. Can you point us out where the problem is?
So in comparison, let me compare the older MRI with the newer MRI. The older MRI shows a protruded L5S1 disc in the sagittal T2 weighted image, and here in the same sagittal T2 weighted image, we can see that the disc has now popped out and migrated superiorly, as in my pointer.
All right. So, Dr. Ankit, do you think that we probably did a mistake by putting the patient on the conservative treatment, since now we have landed up in a significantly huge disc which has prolapsed? And initially the disc was pretty small. The patient didn't have neurology before. The patient is having neurological deficit, grade 4/5 and hypoesthesia now. Should we have not put the patient on conservative treatment?
No, not at all, because majority of the initial episodes of radiculopathy responds very well to conservative therapy, and the patient also had responded well. This is a repeat episode of herniation with a new fragment going up cranially and causing a new level of compression. So the choice of initial conservative management cannot be cautioned. But yes, the decision of doing a new MRI was more than welcome, because that will probably help us in doing a surgical plan much better than relying upon the old MRI.
Right. So do you prefer to get a new MRI done when the patient's symptoms have changed, or just if you plan a surgery?
So if the symptoms have changed, definitely a new MRI helps, because the patient might be having a proximal level herniation as well, apart from the L5S1, and we need to treat the both.
Right. And since this is a new herniation which has come up, do you plan to get a contrast enhanced MRI, or a simple MRI is sufficient?
No. So she has never been operated previously at this level. So I will not be getting any more information with the contrast MRI. I will be happy with the new MRI, plain MRI.
Right. Perfect. So Dr. Shreel, over to you.
Yes, sir. So having investigated her further, now we've explained the gravity of situation to the patient, and still we explained her, we gave her 3 choices: conservative management versus selective nerve root block versus surgery. And now the patient opted for a microlumbar decompression surgery, and post-operatively the patient was very happy. Her right lower limb symptoms had diminished and she was again back to her activities of daily living.
Okay, so can you go back one slide back, please? So patient opted for microlumbar discectomy. Dr. Sai, which would be the option of treatment for you, would you go for a fusion or would just go for a discectomy?
So obviously, we would give this options to patient first. We would like to discuss everything with the patient about a conservative trial. But I would definitely would go for a discectomy first, because patient has predominantly leg pain and less of back pain. So first, I would go with the microendoscopic discectomy.
Right. So, what are the points in favor of a discectomy versus fusion that you are seeing on the you are seeing radiologically in this patient?
So radiologically, first of all, it's a very large fragment disc, but patient does not have any back pain. Plus, she does not have any instability on her X-rays. So I would, and also she's an obese patient, and so obesity and all that factor goes in the favor of fusion. But here, because she does not have any back pain, there is no instability, plus only leg pain, I would go with the microtubular endoscopic decompression.
So we may ask Ram sir about his treatment plan. We have a patient over here. The disc has significantly increased. The patient does not have any back pain. There is no instability on X-rays. Shall we go for a discectomy? Shall we go for a fusion? Or we lay both the options with the patient and let the patient decide?
Well, truthfully, in such a patient where the patient has not had back pain, there's no obvious instability, we should counsel the patient that if she's going for surgery, she surely needs a nerve root decompression. Anything more than a nerve root decompression in this situation may probably be an overkill. Hence, in the absence of back pain, I would offer her a micro decompression. Whether you do it through a tube, whether you do it with McCullough's retractor, whether you do it percutaneous, the choice is between the surgeon, the center, and the patient. And the job is to make that nerve comfortable on the right side and to make that entire fragment out as far as possible, clearing that nerve root. That's the aim of the surgery today.
And if the same patient here is having a settled disc at L5-SM, but if she had a tall disc, whether that will have any implication on the decision making?
Well, again, I would counsel the patient, but I would treat the man and not the scan, which means I would go with symptomatology first. If this patient with a tall disc also has leg pain, which is 7 or 8 on 10, and the back pain is 1 or 2 or 3, I would counsel the patient, tell the patient that you surely need a decompression. And if you have a low demand back, you'll probably get away. If you have a high demand back and she's much younger, this is an elderly lady, she's much younger, then I could consider the option of an instrumented fusion, but I would still have a very, very low threshold to do only a decompression.
And does modic changes or a small node have any implication here?
Modic changes, small nodes all come at a much later stage. I do not get carried away by all those things. I basically treat the patient. I would look at the pain of the patient and the demand of the patient. If it's leg pain, the decompression comes in. Because both you and I know that we may convince ourselves that instrumentation is necessary in a particular patient, but we have to look at the bigger picture, the larger picture. Will this instrumentation actually invest for a future surgery, like an adjacent segment? So just be very, very careful where you take a call between decomp alone versus decomp with instrumented fusion.
Agreed.
So I have learned this in the last 30 years that I have moved to lesser instrumentation where it is not needed.
Right, sir. So the opinion of the house for this particular patient that we're discussing is that the patient should have gone for a microlumbar discectomy, and this is what has been done for the patient. So one last question, Ram sir. This patient is मुझे 100% ठीक होना है. इसके बाद मुझे कुछ नहीं होगा, उसका क्या guarantee है? If this is what the patient usually comes and tells the surgeon. So how do we counsel these kind of patients in terms of probably from the failed back syndrome point of view?
I am very, very clear whenever I counsel any of my patients. One, I do not ever give 100% guarantee to any patient. If they insist I tell them to find God because I'm not so. I look at it like this, that it's either God who can give you 100% guarantee or somebody who's lying to you. I do not claim to be God and I don't like to lie to my patients. So I tell them very, very clearly, microlumbar decompression has the highest success rate among all low back surgeries in my hand. It is also commensurate with international literature. However, it is not 100%. I tell them about 95% of my patients are very, very happy immediately after surgery. 4% takes slightly longer to become happy and they may not become very, very happy. 1%, despite the best of efforts, will remain unhappy post-surgery and may need revision surgery immediately post-surgery or soon thereafter. I also tell them among the 95% who are very, very happy, 7% will come back for a revision surgery sooner or later, which means that the recurrence rate is 7% plus of a recurrence of a successful lumbar decompression by whatever modality.
Right, sir. So it is very much necessary that we... It is very much necessary that we counsel the patient adequately right at the time of index surgery, as Ram sir mentioned, in terms of also telling them the chances of recurrence, which are as close to 7% and has been mentioned in literature. We have a question from Dr. Sai.
Sir, as you mentioned that we do not treat patient radiologically, but when you see a patient with a large annular tear with a large disc on an MRI, or patient is an obese, or patient is a smoker, do we think of fusion or do we counsel the patient more in such cases?
As much as you are looking as large patients, smoker, BMI on the higher side, tall disc as an indication for fusion, I also look at the same patient as a failure of instrumentation and fusion at the same time with all these parameters. So I have to balance that. And the best thing is try to do less and get more. I also tell my patients, and many of them where it's a very, very difficult decision, both for the patient and for you. We went through such a patient very recently. We then actually counsel them that let's do it step by step. Let's do a decompression alone and wait. And there is a very strong possibility you may not need an instrumented fusion because decompression by itself is actually part of a much bigger operation. And believe me, many of them understand that if they do a decompression fusion, if they lose their body weight, if they quit smoking, the chances of their needing another surgery becomes less. And God forbid they need the other surgery later when they've given up smoking and they've lost body weight, the success of that instrumented fusion will be much better. So this is the way that I tackle these people.
Yes, thank you, sir.
Right. So over to you, Dr. Shreel. So the patient is symptomatically better. We agree with the house that there is a microlumbar discectomy, which is the right decision that has been taken. So please go ahead.
Yes, sir. So we did a successful microlumbar decompression surgery and we followed up the patient on the post-operative period. The patient was symptomatically fine until 1 year of follow-up when she complained of the same pain again of right low limb radicular pain, positive SLR, S1 was hypostatic than left, and this time the patient had a right ankle plantar flexion and FHL weak, slightly weak. Now here is the nightmare. So what the nightmare starts from here, that the patient has symptomatically been relieved for 1 year and now the patient comes with the same symptoms again.
Right. So it is the same distribution of pain, is it?
Yes, exactly the same, sir.
So Dr. Shreel, what would be the next plan of treatment? Would you just probably counsel the patient that this is a kind of pain that may occur on and off, and will gradually reduce? Or do you think that is a sudden onset new pain which has come up and you will probably investigate the patient at this point?
So I think both should be done. Counseling of the patient is necessary, but if the activities of daily living is affected and the patient is in pain, then yes, we should investigate the patient further. But counseling of the patient regarding these kind of waxing and waning of symptoms is necessary, sir.
Right. So, Dr. Ankit, how frequently do you see recurrence of symptoms at 1 year, and what is going in your mind at this point of time with regards to the cause of the patient's symptoms?
So recurrence at 1 year is not very common, but yes, when a patient has had a symptom-free period after the surgery and comes back with a severe intensity or probably a more higher intensity pain in the same leg, the same dermatomes, I would be suspicious and I'll get it investigated at the earliest.
Right. So we agree that we have to investigate the patient in addition to the counseling that needs to be done. As regards to the primer, the index procedure, when the patient first time came to us, we probably would go slow, put him on medications and then investigate. But this patient needs an early investigation as well as adequate counseling. So what did we do, Shreel?
So we investigated her further, sir. We counseled her, we gave her medications to relieve her pain, and we investigated her further. And this time...
So, Doctor, just hold on. So, Dr. Sai, what all investigations would you like to do for this patient now?
I would, again, now, this is a case where I suspect there is a disc at the same side. And I would obviously suspect a recurrence in this case. And in this case, I would like to get an MRI done, and this time a contrast one. Also, a flexion extension X-ray.
Any particular role? Why do you need? We have not instrumented the patient. We have not put any implants. This was a simple microlumbar discectomy was done. Then what would be the need for an X-ray in this patient? And why would you need the dynamic X-rays? Won't a simple X-ray do?
No, so it is necessary to rule out the instability in this case, iatrogenic instability or any kind of instability if it has caused. We need to rule out in this. That's why a dynamic X-ray films is necessary. Within contrast MRI, obviously, both.
Right. So, Dr. Shreel, did we get both of them?
Yes, we did.
Can you show us what did it show?
We did a dynamic X-rays of the lumbar sacral spine. And here we could see that there was no gross instability. The pars was maintained, and there was no instability iatrogenic created in the primary index surgery. We went ahead and did a lumbar sacral spine with screening of the whole spine, and we could see that the disc, there was a recurrence of L5S1 disc. Now, without a contrast MRI, it is very difficult to differentiate whether the space occupying lesion is either a disc or a scar tissue, as mentioned by Sai and you. So that's why we got a contrast MRI, which shows increased uptake of the contrast in the scar tissue because it is highly vascular, and no contrast taken by the disc.
Right. So basically, you mean to say that if it is a scar tissue, it is vascular, it will be taken up by the contrast and the whole area will be blushed with contrast. But
Yes.
this probably being avascular, it will show a halo sign which is seen on the right-hand corner. So the disc will probably not take up the contrast and the surrounding whole area will take up the contrast.
Exactly, sir.
So our diagnosis, which we thought when the patient had come to us after 1 year, that this patient is probably having a recurrent disc herniation on the same side at the same level is right.
Yes.
So what did we do next?
So we explained to the patient now that there was a herniated disc recurrent at the same level, but we still went ahead and we gave patient all three choices. We explained the patient regarding the role of conservative management with medications and analgesics, a root block, or a revision surgery.
So,
Okay.
Dr. Ankit, what would you prefer to start the patient with, or you would directly put surgery on the table for the patient at this moment?
I will definitely try and counsel the patient for getting a repeat discectomy done, considering a new onset hyposthesia and weakness. And that will be my inclination towards the counsel for her.
Right. So So Dr. Sai, would you plan for a conservative treatment or you would directly put surgery for the table? What is your opinion?
This time, because again the patient has come with a pain which her ADL is affected, activity of daily living is affected, plus she has neurology involved this time. Again, I would consider surgery for this patient, and I would not go for a conservative trial. I would just push her for surgery this time.
So can we ask Ram sir, sir, when the same patient had come to us with a similar neurology, we had given the patient a fair trial of conservative treatment of a month or a two. But now with this patient, when the patient has come back with similar symptoms, it has just been probably a week or two. Is it right to put the patient on conservative treatment or we should go for a surgery immediately?
Okay, this patient walks into my OPD after 1 year of being very happy with my treatment. Says that she's got these recurrent symptoms for the past 1 week. It's taken her 1 week during COVID times to reach me. She manages to come and see me. Well, the first thing I will do is I would like to give her some pain relief. So I'll go back to what is my age-old, tried, tested, which is pain medication, including something like pregabalin or gabapentin, and sort of giving her that pain relief and telling her that this is what you're going to take from today onwards. Maybe I'll double the dose, which I normally give 75 milligrams at night. I may give her 150 milligrams. So that's one part of the discussion. Second part, I will tell her that today you have a fresh MRI which says that there is a mechanical cause for this. And this mechanical cause is as big, if not larger than the previous cause. It also says that there is a scar tissue around it, which is also making that area a little bit weaker and more prone to delayed recovery. Having said that, I would then discuss with her the need for another intervention. Medication is started. If she is ready for another intervention, I would not offer her a block. But if she has for any reasons to delay the intervention, whatever it may be, in our country there are reasons to delay, only then I would offer her another block, but telling her very clearly, this is not treating the cause, it's only temporarily hiding the effect. And the discussion for surgery would be done. The only discussion here for surgery today would be between a revision decompression versus a decompression and instrumented fusion. Here, it depends on a lot of things. You're dealing with younger people who want to have flexibility and who have had a recurrence and who otherwise have significant leg pain only, hardly any back pain. I would very strongly recommend something like a revision decompression. That means do the same thing again and expect a better result this time. However, if I have somebody who's grown older, whose BMI has worsened, who's become fatter, who's become lazier, is sort of now bed bound, quality of bone is plus minus, I would then need to look at instrumented fusion. So it would all depend on my present second set of counseling. Yes, in the second set of counseling, I would be slightly more open to instrumented fusion than I was on day one, because there has been a recurrence and because this patient is among those 7 patients out of 95 who had done well, who came back to me again. So this is where I stand today.
Right, sir. So both the options are right, but it depends from the patient to patient that we need to undergo only a decompression or a decompression and fusion surgery. But sir, then the patient, if we decide to go for a revision decompression, the next question is, doctor, will this disc come back out again? Will there be a reherniation, and what are the chances of it? As well as what are the success rates of the revision surgery?
My success rate of a revision surgery will drop from 95% to about 85%. My complication rate will increase from 1% to 2%. And my chances of a re-revision will go up from 7% to 14%. And I put all these cards on the table.
Right, sir.
I make it very clear. One, success of a revision is not as much as the success of the primary surgery. So it will fall from 95 to 85%. But today there is no go. You are stuck in a bad shape. You need to go ahead. Next, complication rate will surely increase because I'm dealing with scar tissue. And third and final, will this recur again? Yes, if I do only a decompression and leave it alone, there's a higher than normal chance of you having a recurrence. It was 7 out of 95 the first time, and now it will probably be 14 out of the 95.
Yes. So, sir, what are from the surgeon's point of view, what are the things that probably we should keep in mind while undergoing a revision surgery?
Quality of bone in the elderly obese woman, very, very important if you are planning instrumentation. If I'm dealing with a postmenopausal lady, I'll always check the bone density at this stage, because if she's not been very, very active, she may have even deteriorated further. And if I operate or instrument an osteoporotic spine unknowingly, I'll be actually entering into a longer failed back surgical syndrome exercise. So that's extremely important. Plus, in a failed back surgery, it's extremely important to evaluate the psychological status of the patient and the family. They don't come only with the mechanical problem. There's a lot of other sort of baggage that they're carrying. All that needs to be taken care of in failed back surgery syndrome.
So like this patient is L5S1, do you have less threshold for fixation for patient Indian women who do ground level activities?
I have a lesser threshold for doing fusion in ladies who are going to be doing activities at a lower level. You're absolutely right. However, all my patients, I have a very, very sort of, I don't offer them surgery unless they really are indicated for it. And I make it very clear to them, even if you're doing ground level activities, if I am doing any surgery, it's your responsibility as much as mine to protect your back. So I counsel them and sort of scare them of a third surgery, and I'm doing the second surgery.
Yes, sir.
Right. Sir, first time if we have done a minimally invasive spine surgery, are there any, is it necessary that we have to go for an open surgery, or we can deal with revision surgeries also with MIS techniques?
You can deal with revision surgery by MIS technique when you've done minimally invasive the first time. In fact, you can do a minimally invasive revision of an open surgery done primarily. Between you and me, when you do it, when you have an open surgery done the first time and you're doing it minimally invasive from the lateral side, from the Wilsey's approach, basically you're going from that side. And if you're planning a T-lift, you're actually much safer off than if you were to go through the central scar all over again. So actually minimally invasive surgery by using a tubular retractor or whatever you may want to do, minimal access is a brilliant solution for revision surgery.
Right. Right, sir. So, Dr. Ankit, Dr. Sai, any further questions regarding the planning or regarding this case before we discuss what has been finally done with the patient?
Let's go ahead and see what Dr. Shreel has done with the patient.
Right. So, Dr. Shreel, can you let us know?
Yes, sir. Having explained all the modalities of treatment now to the patient then did not want a recurrent disc again and opted for a fusion surgery. We went ahead and did a T-lift at L5S1, and now the patient is symptomatically better, sir.
Right. Thank you so much, Dr. Shreel, for a wonderful case which has taught us so much. So now we move on to the second case for which we call upon Dr. Ankit. There's one question. Please elaborate the role of neural surgery in failed back syndrome, prognosis and possible treatment choices from Dr. Nikhil. I think it has been fairly discussed in the previous case discussion, and a lot of things will be discussed in this case discussion too regarding the question which has been asked. So Dr. Ankit, can we have it?
Ankit, you may be muted.
So am I audible now?
Yes.
You're audible.
Yes. So after having seen a case scenario of a recurrent disc being treated by a fusion surgery, let us move on ahead and see the other aspect of a failed back syndrome, which is called the adjacent segment degeneration. So here is a 73-year-old lady who had been operated for a L4-5 instrumented fixation way back in 2004. She's an ex-teacher, active till date. She now presents with low back pain radiating to the right lower limb for a duration of 2 months. It is dermatomal. The paresthesias are bilateral, right more than left. She has difficulty in sitting, walking, climbing stairs. Claudication distances of around 5 to 10 minutes, but she is neurologically preserved. So what do we do ahead? She has a L4-5 TLIF. This is how it is in the present date. So should we conserve her or should we investigate further? If yes, how?
So Dr. Sai, can we have you for this? So we have a patient who has probably a mechanical low back pain operated in 2004 with neurological symptoms. What all investigations would you plan for, or we just go ahead with the conservative treatment?
We would definitely, the X-ray is the old X-ray or the new one?
So this is the latest X-ray.
Okay. So obviously we would like to go for again a dynamic X-rays to check for any instability above the operated site, and to see for the fusion, obviously the new X-ray, and an MRI to see what is happening there on the above level.
So what can we see on the X-rays that are being put forth by Dr.
This is the standing coronal view, AP view, the flexion and extension here.
So I can see there is a slight instability at 3-4 level, which is the adjacent to the previously operated site, and 4-5, which is operated, is fused, completely fused, and there is no movement on the 4-5 level. So obviously the problem is on the above level 3-4, L3, L4.
So you suspect stenosis at the adjacent level.
Adjacent level.
So Dr. Ankit, can you show the delegates how beautifully the fusion can be seen on this X-ray, on the AP as well as lateral views?
On the AP, we can see that there are two B-twin cages with fusion mass seen all the way from edge to edge. On the sagittal views, also we can see the fusion mass just in front of the cages, as well as passing through the cage material, and no movement at the L4-5 level, even on a flexion extension. That means that the level is fused.
Right.
So let us come to the question at hand. What is an ASD and how to identify that? So here are 3 post-operative sagittal X-rays, all instrumented at L4-5 level. Which of this is an ASD? Is it the first one with a minimal listhesis at 3-4? Is it the second one with a grade 1 proper listhesis? Or is it the third one with a grade 1 listhesis as well as segmental kyphosis? Which of these is an ASD? So let us understand what exactly is an AS degeneration versus an AS disease. An adjacent segment degeneration means a radiological finding of instability, usually proximal to an instrumented fusion level, whereas an adjacent segment disease means the patient has signs and symptoms which are matching to the ASD seen on the radiology. So basically, the patient was initially happy, radiologically positive findings, and now the patient becomes unhappy, has symptoms in the presence of radiological signs. So a patient with clinical radiological correlation and a documented adjacent segment degeneration is classified as a patient with AS disease. So this is the immediate postoperative X-ray of that same lady in 2004, in which you can see the instrumented fusion, instrumented fixation, as well as the between cages, and a 2-year follow-up in 2006, wherein we can see early signs of L3-4 listhesis. But at that time, the lady was completely asymptomatic, was going on with her routine, and this was termed as radiological ASD, but not a clinical ASD. So this is the current MRI. Dr. Shreel, what do you see here?
Yes, sir. So in this MRI, we can see that there is in the sagittal T2 weighted images, we can see that there is instability at L3, L4, and there is a listhesis at L3, L4, and on the axial cuts we can see that the L3, L4 is stenosed. There is a stenosis at L3, L4, and also at L2, L3, sir.
So any other investigation that you would like to do, or the dynamic X-rays and the MRI, which we are seeing here, is sufficient to decide further and probably conserve her or give her all the options of treatment that is coming into your mind? What will be your decision right now? She has just symptoms since 2 months. She's able to walk around 10 minutes and there is no neurological deficit yet.
So if her activities of daily living are within her limits, that means she's able to perform her activities of daily living, then yes, we can still conserve her, having explained her all the pros and cons of conservative versus a second surgery. However, if the 10 minutes of claudication distance is bothering her, if she is very active, then I would like to investigate her further with a contrast MRI.
So she is a typical elderly retired lady doing her home chores, running errands, and she's able to do that right now. She is not at all debilitated because of the pain, but yes, she is concerned because it has appeared something new in the past couple of months. So the patient was well informed about the red flag signs and conserved, but yet she comes back 2 weeks later with an unbearable pain. So the pain intensity has increased from the one which she had 2 weeks back. She now has an urinary urgency and she is unable to sit, stand, or walk comfortably even for a few minutes. So Dr. Samir, what are your thoughts at this time? Will you reinvestigate or will you change your course of treatment? How will you go about?
I think now I will be very much aggressive with the patient. Initially, as Dr. Sheel mentioned that, since the patient's activities of daily living were not affected and we were putting forth the conservative management as well as the operative options in front of the patient. But at this point of time, when the patient has developed a urinary urgency with progressive neurological deficit, I think that it is an absolute indication for the surgical intervention at this point of time.
So what are your thoughts? What kind of intervention that you are planning for her? Is it a conservative treatment right now, or is it a root block and see and observe, because she doesn't have any objective lower limb weakness apart from the urgency? So urgency is as important as weakness, or will you grade weakness as more important than urinary urgency? And seeing the coronal X-rays here, she has a little bit of degenerative scoliosis as well, L2-3 retrolysis as well. So even though the MRI is showing that L3-4 is the more stenotic level, will you be thinking of doing just one level proximal surgery, or what are your thoughts here?
I think only one level proximal surgery would be adequate. In these patients, I think doing less is more. And addressing the symptomatic level, which is already also correlating on the MRI, that is L3-4 stenosis, I think that is a culprit level, and I would be happy in addressing only that particular level as of now.
So at L2-3, the facets are quite good. There is no stenosis as such compared to the L3-4, which is obviously stenotic, as well as the facets are digging into the lateral recesses. So that is what the surgeon has done. But will you do a single level fixation, or will you think of doing a one level decompression, but yes, a multi-level fixation, considering the deformity here?
So considering the overall status of the patient, that she is an old patient and having an instability at the level above, definitely I would go for a fusion surgery and not decompression alone. As we can see on the history, which has been mentioned, the patient has a fair bit of mechanical back pain also, which correlates with the listhesis that has been shown on the X-rays. So I would probably go for a fusion surgery on a single level, which is above the level that has been fused previously. As far as the deformity is concerned, I would probably, I don't think that the deformity is to a great extent that we need to go for the whole hog and correct up till D10 to S1. This is what I feel.
So Ram sir, since this surgery was done in an era in which we were not yet trained as spine surgeons, and probably we have never seen a between cage or never seen a in-out system, as a senior surgeon, what are your suggestions and what we should be doing for the preparation for the surgery, and how we should be going about handling this particular case wherein we have decided as that we will be doing only a L3-4 fixation and decompression at that level?
Thank you very much for this question, because this is a surgery originally done in 2004, where an INI-OUTI system was used, which is not easily available today. And the between interbody spacer was used from a company called Discotech, which is also not available today. Besides, this lady was premenopausal then and is postmenopausal today. So she's probably gone down on bone density as well. So with all this at the back of my mind, few things that come to my mind. One, I would want to find out the quality of bone and whether in these 16 years she has taken treatment for osteoporosis. If so, where she is on the bone density graph. Next, I would like to have an instrument to remove all these screws and rods from the rear, if not a universal screw removal for the same. And finally, I would probably need to keep a fresh set of implants where I would be able to go to a higher level, which would either allow me to use the existing implants if I am unable to remove them, or go to a stage where I can go beyond these implants if I can remove them and take a decision as to whatever level I would like to instrument. I would agree with Dr. Samir that this lady, though having a degen scoli, is not significantly in that complex LCS stage where the degen scoli is significantly and painful more than 20 degrees for me to consider the whole hog. So I would also restrict my surgery to the neurological level, which is the cause, which is the one above, and stop there. Understanding quality of bone, keeping option of fenestrated screws or cement augmentation, God forbid, it is a borderline quality of bone issue. The other thing, I would also keep at the back of my mind to find out what these original implants were. Because in those days, implants used to be available in one set used to be 4.5, 5.5, 6.5, 7.5, and the other implants used to be 5, 6, 7. If I know the diameter, I would then have the option of upgrading the diameter by 0.5 or 1 millimeters if I were to use the same screw holes at a later date. So these are all things that will go on at the back of my mind when I have to remove this. Finally, even if there is no way that I can get this in and out, I should have a good rod cutter. And if I can cut the two rods right down the center on either side, I can use any instrument and get my entire assembly out. That's all that I have to say here.
So at this juncture, would you like to do a CT scan, sir, to identify if the fusion is solid or the X-rays are self-explanatory here?
Well, I would love to do a CT scan to help my documentation, but as I look at it today, I would be more sort of keen to look at where I'm going forward, which is the next level above. And as I said, to me, this looks pretty good on plain films. Now, something that looks good on plain films will, in my opinion, look very, very good on a CT scan. I do a CT scan when I doubt the plain film. When I see a plain film like this at the end of 16 years of surgery, I'm pretty convinced that this is rock solid.
Agreed, sir. So since here we have documented that it is a solid fusion, would we be removing the implants and keeping the cages there itself, or will we be fixing from L3 all the way to L5? What will be the choice here? Just an L3-4 instrumentation and leaving the L4-5 interbody as it is, or L3, L4, L5 instrumentation and doing a telified L3-4?
I am not fiddling with the interbody cages at all, because that's not my area of working. My area of working is at L3-4. So I am looking at doing a decomp and stabilization at L3-4. If I manage to get the implants out, I would get all the screws and rods out and probably instrument just 3 to 4.
Yes. So this is what was done for her. A removal of the L4-5 instrumentation, L3-4 decompression and TLIF. She's happy after that, symptomatically significantly better and gradually performing activities of daily living. So the learning points from this case scenario of an adjacent segment degeneration was that always keep an eye out for ASD in patients with previous instrumentation which show symptoms. When we are attempting a revision surgery, the knowledge of incumbent implants, as Dr. Ram sir nicely said, is absolutely essential, and an appropriate implant removal set on standby makes things easier. Always prepare for intraoperative surprises which may warrant a course correction, and a revision surgery brings with it elevated chance of dural events. There is a high chance of dural tear as well as neuropraxia. Substances such as fibrin glue should be kept handy in order to prepare for such scenarios. Thank you.
Thank you so much, Dr. Ankit. And now we move on to the part of the webinar that we have all been waiting for. We may now call upon Ram sir to help us how to treat, manage, counsel the patients with failed back syndrome.
Thank you very much, Samir. Thank you to the entire team for this excellent presentation today. This is bounce back, failed back surgery syndrome, challenges versus options. I personally don't like the nomenclature of failed back surgery syndrome because I don't have failed hand surgery syndrome. I don't have failed trauma surgery syndrome. I don't have failed arthroscopy surgery syndrome. So why is it that we as back surgeons have to face this? But then probably it's going to stay with us because we make unhappy patients less unhappy. I'm here walking you through the last 3 decades, what I have learned in a nutshell. I must say that failed back surgery syndrome is the primordial deterrent to a spine surgeon in the process of achieving his holy grail. All these patients which I'm sharing with you are patients whom I have encountered in the last 3 decades, either directly under my care or who have visited my clinic from elsewhere. So I have patients who have 7 pedicular screws, all of which are not in the pedicle. And here I have many of those pedicle screws which I can remove without anesthesia. At the end of the day, I'm trying my best to share wisdom rather than knowledge. At one stage, we have only information, then we channelize it and make it knowledge. And then after the knowledge, whatever we throw out, the rest that we keep inside is wisdom. I have learned from my teachers, that is Professor Nandulad to the right, and my senior colleagues, Shekhar Kumta, Surya Narayan and Narayan, all of who were registrars with Dr. S. Lad, that when life gives you lemons, you must learn how to make lemonade and convert adversity into an advantage. The teams that I have worked with are usually orthopedic spine surgeons, but we also have neurospines and fellows working with us. I have analyzed 30 years of practice and picked up 220 patients who came to me, 228 as a part of this study. These I divided into 3 categories. 1, implant-related failed back surgery syndrome, and they were the majority, 90 patients. Surgery-related intraoperative adverse event, 72 patients. And there were 66 patients who had nothing wrong with them, but was still very, very unhappy with the result. These included, as I said, patients operated by our teams, as well as those operated elsewhere. From a year and a half of follow-up to 28 years of follow-up is what I share. All these patients were symptomatic and uncomfortable enough, despite all non-surgical care, and were willing and consenting for another operation. This is the set of patients I'm sharing. The first set, 90 of them, they had malpositioned obvious things which I could look for, screws, cages, spacers, and they came with residual, recurrent, or fresh neurological symptoms. What did we do in that? Well, this is a very interesting case. Came from the interior of our state, operated there, and came, believe me, much later down the line with a neurology. This is something that came from overseas. A screw put in, came to me at 2.5 to 3 years, recalcitrant, unbearable radicular symptoms. What have we done? Either we've removed the implant or we've repositioned the implant. That's what I show you here. There are some times when you have to both remove and reposition. This is my own patient where I had done a decomp with a solid fusion at one level and an intertransverse at the other, posterolateral. 8 weeks down the line, cage popped around and said hello to the neural elements. Patient was very, very uncomfortable. We had to both remove and reposition the implant. Coming to category 2, where there has been some intraoperative adverse event or a sequelae during or after surgery. These were things where nothing appeared to go wrong on day 1. There was an incidental durotomy or an unknown inadvertent pars excision or a post-op surgical site infection, discitis, or even that much dreaded adjacent segment disease, usually suprajacent, rarely subjacent. There were a few with delayed or non-unions of the interbody or posterolateral levels, and residual or fresh neurology and significant axial pain on instability. This is one of the patients who again came from overseas, who had been operated in India, went overseas, stayed there for some time and came back. This is what this person came with. Post-operatively, contrast, patient was not improving neurologically, in fact worsens neurologically post-surgery, and had pus pouring out from the rear. I did a cleanup job from the behind, cleaned it up, got all the implants out, kept the anterior implants intact, and the patient went on to heal, proving to me that there was a discontinuity between the anterior and posterior set of implants, and that was a proper decision on our part to have not taken the anterior implants out at that stage and just done the posterior metal exit. This is a case which has taught me the most. It was a mobile L45, let's call it 45 for discussion, last mobile segment, sacralized L5, instability, degen listhesis, something which I enjoyed doing for the first 10 years of my practice, and this was probably in the early 2000s that I did this surgery. I went in, had to decompress 2 levels, and I was very fond of doing fusion at one and mobile segment at the other. So I used a flexible rod at L34 and a solid interbody with a titanium spacer with a reduction at 4.5. Despite the flexible rod at 3.4, he developed adjacent segment disease. This came as a surprise because I was doing this to prevent ASD. Unfortunately, it happened. So then I went 2 levels above and converted the flexible rod into a solid rod with posterolateral fusion. Did well for 7 to 8 years. Came back to me as he grew older with an adjacent segment disease at the upper lumbar spine with a cutout movement getting into the superior disc space. Mind you, this is what it looked like post-op, looked ideal placed. But over 7 to 8 years, this is how much he cut back. And finally came with a neurology. This stage he could not wait, and I decided I was probably too close to the thoracolumbar junction and went by the teaching at that time, went above, put a domino and went up to D10. Well, my happiness was short-lived this time. Less than a year, he popped a disc out at the D9-10 level. You can see that huge disc, and came with a myelopathy this time, lower thoracic myelopathy and neurology. Well, we couldn't wait this time. He was growing older. In the meantime, mind you, because of the bone density issues, we had started him on teriparatide. And under cover of teriparatide, we went ahead this time, went still further up to D4. Well, I thought we've done it this time, and we were very, very happy. Such patients become your best friends, especially if you operate them more than once, and every time they come out and they start walking again. So they are very, very grateful. Completed his teriparatide. There was no monoclonal antibody or denosumab available at that time, so we called it a day. We were very, very happy. So was he. But within a year, he then developed an adjacent segment disease at the D3-4 junction. The bone collapsed. He developed a disc and a retropulsion. This was probably the last straw on the camel's back. He just had 3 thoracic vertebrae above that. And I went in this time and stabilized those 3 vertebrae, not just with screws, but I also put sublaminar wires, and I said my prayers. Well, he did recover again. He spent another 2 years of reasonably good quality of life, though homebound, though using a walker, but bladder bowel recovered. Finally, a cardiac episode took him away about 2 years back. So this was a complete almost 15 years which we went through together. I really wouldn't know what to do next. I may have had to go into the cervical spine, but this man taught me a lot. Finally, coming to those 66 patients where I still don't have an answer. These were patients who had perineural scarring, laminectomy membranes, arachnoiditis, sympathetic ganglion symptoms which were non-dermatomal at times, resulting in some vague symptomatology. No correlation, mechanical and imaging and symptoms. We had unhappy relatives looking at me while the patient was out of focus in the background. What did I need here? Well, I need to treat these patients without pharmacology. Advise, counseling, spend more time. Depression and anxiety are very common in such patients, and we need to have highly skilled communication skills. Always remember, you are neither above nor below the patient, but besides the patient. Listen to them, respect their views, have open communication about all treatment choices, discuss all management options, allow them to ask any question they want, ensure that they've understood every word, be aware of their language, be aware of cultural influences that they may carry. And finally, all the communication issues need to be compensated before you come to a final decision. Having said that, what were the measures I did? I corrected all the hardware as I showed you in category 1. I did additional soft tissue and bony surgery in category 2. And it was category 3, which was the most difficult, where we had pain specialists or physiatrists help us most of the times. But a few of them did need some limited decompressions, especially those who had root sort of issues or who had scarring around the root where nothing else seems to be working. Having said that, those where we just did implant change, they stayed the lowest in the hospital after the surgery for a second time. Those where we had more than just change of implants, they stayed for 5.5 days. And the third set of patients where nothing was very clear stayed much longer. Yes, whatever revisions I did, I had higher incidence of dural events and I had to use tissue sealants more often than I did in primary surgery. These patients also had a higher unplanned return to the OT for relooks at the wounds, drainage of hematomas, wound not healing, wound dehiscence, etc. Finally, those with category 1, where it's only the implant was amiss, they had 92% excellent results. Those which were category 2, which had bony and soft tissue, but matching at 68%. While finally in category 3, who were unhappy and we had no actual mechanical cause, only 56% of them did well. Having said that, we had clinical and radiological outcomes which were similar. I have introspected on this very often, and I have concluded that those with implants will do best once you correct them. Those which are non-specific will do the worst despite the best of your efforts. We have to have a good risk-benefit ratio evaluation with the patient when we are going in a second or a third time. Counseling should be with clear intent to treat and avoid unrealistic positive outcomes. And this should be very clearly mentioned to the patient when he's going in a second or a third time, because these patients come with huge baggage of functional overlay. Please understand, like life, managing failed back surgery syndrome is not about reinventing the wheel. It's about getting a new set of wheels which need to run in perfect harmony. Mind you, the wheels need not necessarily be circular. You have to think out of the box and remember what Samuel Beckett said: ever tried, ever failed, no matter. Try again, fail better. And before any surgery, primary or revision, I say this prayer, and so should you. And I quote Reinhold Niebuhr: God grant me the serenity to accept things that I cannot change, courage to change the things that I can, and wisdom to know the difference between what I can change and what I cannot. Please remember, as surgeons, we can only change the anatomy and hope, yes, hope that this change in anatomy improves the physiology. Thank you very, very much for a patient hearing. We can strive for excellence, but remember, we don't live in a perfect world. All the best. Stay safe, stay happy. Thank you for a patient hearing. God bless you.
Thank you, Ram sir, for the excellent demonstration of all the three different categories of failed back syndrome. As we move to the end of this bounce back session, I would like to invite Dr. Saijot Rao to take us through the review of literature and let us know what the world has done about and research about the failed back syndrome. Over to you, Dr. Sai.
So good evening, everyone. Everything about failed back has been already discussed in this webinar. I would just like to get an overview of some articles which are being published previously. So let's move ahead with the articles. So what Moni in 1988 said, we in the industrialized society have a significant burden, must explain why the problem of chronic disability in third world countries is virtually unknown. Have we, the sophisticated scientific physician, create our own monster, the failed back syndrome? So as the definition by Follett and Dirks said, the surgical end stage after one or several interventions on the lumbar neuroaxis indicated to relieve lower back pain, radicular pain, or combination of both without effect. The second definition was brought to us by Volkswagen when the outcome of lumbar spinal surgery does not meet the pre-surgical expectations of the patient and the surgeon is failed back syndrome. So now we go on to an article which is a failed back surgery syndrome, a review article in Asian Spine Journal. It's already been discussed about the management, the role, the factors. Still, I would like to give an overview of this article. So the factors which leads to a failed back syndrome after surgery are few factors. Like first is a patient factor. His psychosocial well-being. A smokers and obese patient have more risk of a failed back surgery. Second is the operative factors such as the number of prior spinal surgeries. The more the surgery, the more failed results we get. Poor surgical options. The sometimes surgeon choose fixation over a pure decompression, because of which there is a poor surgical outcome. And wrong level decompression. Fourth is the intraoperative errors, which gives to a new segmental instability. Fifth is the wrong screw placement or screw placement errors and implant breakage. Sixth is the loss of sagittal balance, reduced sacral tilt after surgery. All these are the effect of we give lordosis or in a surgery during the instrumentation, which give rise to which reduces sacral tilt or pelvic incidence, giving rise to adjacent segment. And last is an inappropriate surgical choice. Third, post-operative factors is the early and the late factors. Early factors can have a hematoma, an infection, a pseudomeningocele, a nerve injury, and late factors such as the altered biomechanics, which is a transition syndrome, changes in load distribution, and recurrence, which is a lumbar disc. So how do we assess this patient? So assessment of this patient is taking a detailed history of this patient, asking about the psychosocial well-being of the patient, asking them if they have any psychiatric comorbidity before. And third important point is sometimes the patient has a workers' compensation claims, because of which they come back to us again and again. So a detailed pain history of the patient is very important. Clinically correlating the pain of current pain of patient with the earlier and previous one is also very important. Second is a physical examination, which is mainly performed to eliminate any ominous diagnostics. Thorough and repeated examination pre-operatively must be done, and watch for a progressive neurology is an important sign of physical examination. Third are the investigation, which are the plain X-rays, dynamic films, MRI with contrast, and MRI with gadolinium. So how do we manage this patient? First is conservatively by supervised exercise programs, improving patient core strength, spinal range of motion, and NSAIDs for axial pains, anticonvulsants for neuropathic pain. When repeat surgeries is one option. When do we do it? We do it when there is a disabling or a progressive neurodeficit, quad equina syndrome, established instability, When we see a pedicle screw error, we do a removal of pedicle screw instrumentation, significant adjacent segment disease, and periprosthetic loosening. There is one more option called a neuromodulation, which has been tried now in years, called as spinal cord stimulation. So what do we conclude? So various patient-related factors may lead to unsuccessful outcome besides the presence of surgically ameliorable pathology. Axial back pain cannot be treated with surgery. So understanding this point, they may not respond to the treatment. If patient has axial back pain, surgery will not be able to help. Importance of a competent multidisciplinary team is very important to treat a failed back syndrome patient. Engagement between physicians, psychologists, physiotherapists, and other allied health professionals is essential. The spinal cord stimulation is a key in absence of viable surgical alternative. We'll have a quick review on few articles. First article is the risk factor of adjacent segment disease requiring surgery after lumbar spinal fusion. The key points are: it was predicted that 10% of patients would undergo additional surgery after treating ASD within 10 years of index lumbar fusion. So there are 10% of people who would require a surgery, but patients with age greater than 60 years have another independent risk factor. Second paper we have here is the treatment of a lumbar adjacent segment pathology after a previous lumbar surgery. So yes, operative management for clinical adjacent segment pathology, that is CAS, should be considered after failure of non-operative management. They have been focusing on one thing, that adequate non-operative conservative trial for a failed back syndrome patient has to be given before even considering an operative management. So when considering an operative management, clinical judgment, radiological appearance, and patient's preference should be a guide operative intervention. If a patient's disability secondary to lumbar cast is high enough, consideration should be given to operative treatment. So there is one more article which says failed back syndrome, who has failed. So this paper have said that failed back syndrome results from a cascade of medical and surgical events. It's not the only one thing; it's a cascade. So who do we blame? And apart from the blame game, it should be replaced and focused on few points which are future rather than the past. We should see what has to be done other than looking back into the past. A transition from a mechanical problem to a chronic disease, and redefinition and renaming of this syndrome in order to ensure a more positive approach to the future. Renaming this as a syndrome or a disease, a patient would have a positive approach to a future. One more article we have is the immediately failed lumbar disc diseases, disc surgeries. What are the incidences, etiologies, imaging, and management? So this article says that the immediate failure of microlumbar discectomy occurs in 2.8% of the patients. So they have given a 2.8% of figure. They have, in contrast to typical failed back surgery, most immediate failure are caused either by overseen or reherniated disc material and excessive by root manipulation. So the therapy has to be guided by seeing the clinical presentation of the patient. And the study proposes to proceed to reoperation only in patient with acute deterioration of symptom of radiculopathy or in patient whom adequate anti-edematous therapy was not successful. So last article which would like to present here is the treatment options for failed back surgery syndrome, patient with refractive chronic pain. So this is an evidence-based approach. We'll see what are the material methods for this. A literature review was performed in May 2016 and was updated in 2017. Searches were conducted in PubMed, Cochrane Library, bibliographies on human subjects between 1990 to 2017. So they used keywords like failed back syndrome, Fbss, post-lumbar surgery syndrome, intractable back pain, chronic axial pain, chronic radicular pain, and treatment. They were categorized into RCTs, prospective studies, retrospective charts, and systemic reviews. Books, chapters, non-systemic reviews, expert opinions, all were excluded from the study. So what they found in this study was they proposed that the neuromodulation therapy should be added as a final step of the analgesic step ladder algorithm. They are telling us to follow algorithm where rather than jumping towards the surgery or any intervention, first try the analgesics and conservative line of management, and if not, try the neuromodulation therapy. It also proposes before the implementation of any therapeutic option, patient has to be a comprehensive evaluation assessing treatment option in context to SAFE, which is safe, appropriate, and physically neutral therapy should be implemented. And also, this study gives an option of this spinal stimulation of a frequency at 10 kHz. Active exercises and rehabilitation have demonstrated robust and level 2 evidence with long-term efficacy for utilization in the Fbss patient population. The weakest level of evidence was found for medication and reoperation. For time being, the therapeutic options with strongest and the long-term evidence should be considered inappropriate to Fbss patient. Basically, with all the papers, we found out that conservative trial and medication have a low tolerance. Patient has to be given a specific indicated patient has to be taken for intervention, and reoperation cases should be done only if patient is indicated and is an emergency or has a neurology involved. Thank you so much.
Thank you very much, Sai. That was an excellent review of literature. I think we've gone through everything stepwise. If there are any questions on the chat box, Dr. Samir, we could take them.
Yes, so there's one question. How common is depression in patients with failed back syndrome, and how do we manage it?
Well, I would let you guys take a call, and if you don't want to answer it, then I'll answer it.
So we may have Dr. Ankit to answer the question.
So yes, depression is quite common because most of the times the patients are not able to understand why he or she is having recurrence of symptoms or back pain or leg pain after the successful surgery. So it is very imperative for us as spine specialists to make them understand that this is nothing to be worried about. It can happen, it can be treated, and if required, they can be asked to have the help of a counselor.
Right. So like we saw in literature, it is a multidisciplinary team approach where we evaluate the social well-being of a patient. And if we see if a patient needs help, we can take a help of psychologist and psychiatrist.
Right. So the next question we have, particularly for Ram sir, the question is from Dr. Ashok Bhatt from Vadodara. The question is, if there is no significant instability in a patient of a disc, however, from the X-ray, we suspect that such a patient will develop ASD in future. Will you consider an instrumented fusion or a non-instrumented fusion?
Well, let's be very frank. I'm trying to now decipher the question and answer what I'm understanding from it. If there's no instability in a patient of disc, which means the indication for surgery is nerve root compression with radicular symptoms, and we are dealing with leg pain, in that patient, I'm doing only a decompression. There's no discussion of fusion. Next, however, from X-ray, if you suspect that such a patient will have ASD in future, ASD is something which is not at the same level, but at supra or subjacent. Now, if let's say this patient is an L4-5 disc herniation and has an L5 lysis. Now I'm giving a scenario which is common where there is a symptomatic L4-5 disc herniation and patient incidentally has an L5 lysis with, let's say, grade 1 listhesis. Now this is the only situation where an examination and counseling of the patient would need to be considered. In this patient, again, if it's the leg pain which has brought the patient to me and the leg pain correlates with the L4-5 disc, I shall still restrict my surgery to a micro decompression at L4-5 by whichever modality you may want to do it. But yes, if this patient has significant back pain, has past history where he's suffering for back pain which was related to the 5S1 lytic listhesis, and has come to me today for a situation where 5S1 is lytic listhesis painful, waiting for surgery but not yet precipitated. But 4-5 has brought the patient for a micro decompression. This is the only patient where I would counsel and discuss. If now the patient is willing to again go stepwise, which means allow me to do a micro decompression at 4-5 and maybe look at the 5S1 lytic listhesis later, I would be happier to do that, because in that case, I may prevent a 4-5 fusion. If, however, at the same time I'm addressing 4-5 and 5S1, I may have to do a longer instrumented fusion. This is it. Next, there's a question about whether I consider instrumented or non-instrumented fusion. So the only place where I do non-instrumented fusion is one, a very low-grade lytic listhesis where there is pain at 5S1 with good L5 transverse process and a good ALA, where I can get away with a posterolateral L5S1 uninstrumented fusion, and I've done them in the past. Where else would I do an uninstrumented fusion? Where the patient needs a fusion, but the bone quality is so poor, plus the situation does not allow me to give teriparatide and build up the bone quality over the next 6 months. That means surgery has to be done. Only in that patient would I use uninstrumented posterolateral fusion and probably modify my post-operative protocol by modifying their activities of daily living, maybe a longer brace, maybe building up the bone quality simultaneously and such things. So most of my fusions which I do today are instrumented. Most of them are interbody where there's a gross instability, and where there's a subtle instability, or I'm dealing with a long construct, then it would be a combination of posterolateral and interbody at different levels.
Thank you, sir. I believe there are no further questions in the chat box from the delegates. I leave the discussion open among the panelists if they have any questions for Ram, sir. Dr. Sai, Dr. Shreel, Dr. Ankit. I have one question with regards to the minimal invasive surgery where the pedicle screws are put under CM guidance, and there are chances that it may involve the adjacent, the supra-adjacent facet joint. So are there any papers which prove that the chances of adjacent segment degeneration are probably more when such screws are put without considering the adjacent facet joint violation?
The question is for Sai Jot.
So Sai?
Any papers where supra-adjacent adjacent segment has happened because of violation of the facet joint at the unfused level?
I believe Dr. Ankit and Dr. Sai have been a part of such a paper.
Yes, sir. We have a paper of pedicle instrumentation where we have seen violation of facets, and we have seen that in this, and in minimal invasive surgeries. In fact, in spite of using the X-ray guidance, there are cases where we have seen there is facet violation.
Right. So, Dr. Ankit, what would you suggest so that, while using minimally invasive surgery, any particular recommendations from your paper that we should do to avoid adjacent segment degenerations while putting percutaneous pedicle screws?
So, to prevent ASD, which is because of a facet violation, the principles remain the same as in an open surgery. You have to start as lateral and inferior as possible so that the tulip head doesn't impinge onto the SAP and eat up into it. With regards to minimal invasive surgery, navigation definitely helps in terms of minimizing and reducing that. And early on in the learning curve, we have seen that in our paper that the facet evolution is more in the learning curve when you are earlier in the learning curve, but as you move ahead, definitely reduces. So it's a learning process.
Right. So any other question before we conclude the webinar?
Well, I have a comment which is taking off from the question which Dr. Nikhil Lakar has asked, which is, can you elaborate on the role of neural surgery in FBSS, prognosis and possible treatment choices? Well, prognosis and possible treatment choices we have already discussed. There are certain things which we need to look at as surgeons when we are doing a revision surgery. We need to spend a lot of time in the decision making. I would recommend, if we are doing a revision surgery which is our own or somebody else's, we take more than one opinion, that is our own team as well as some other team, before we embark on a revision surgery. That's important. Next, whenever we are dealing with revision surgery, we are not doing purely with a physical patient, but we are dealing with an unhappy, psychologically affected patient. Hence, this more than one person involved is important. Second thing, have a setup where everything is available, from tissue sealants to all sizes implants to maybe screws of all companies, to cement augmentation, to a post-operative ICU bed, to an unlimited amount of blood being available, to a vascular injury happening intraop or a neurosurgical injury happening intraop, where you may need to reach out for help. So have all this available in that center. Do it in a center where you will be able to handle it. If you are doing it minimally invasive or even open, and you have options of intraoperative spinal cord monitoring, use it. It makes your life slightly better, especially when you're looking at scar tissue and you're in the vicinity of elements where scar tissue and nerve roots, incarcerated nerve roots, are close to each other. So these are things which you have to go step by step. Another very important thing, and this is a very basic step, in revision surgery, we go from virgin area to affected area while doing decompression. So you have to identify a clean area which has not been operated by yourself in the past or by somebody else in the past. And you begin from there. So you go from virgin area, identify the anatomy, and then make your way slowly towards the operated area. Wherever in doubt, stop at that area. If you're not sure of the soft tissue that you're dealing with, you can be aggressive on the bony areas, but have to be very, very careful when you're dealing with the soft tissue. So go along the bone, go back to the X-ray, have a pre-op CT in all these patients where you're doing field back. Go along the bone. As long as you're sticking to the bone with your instruments, your chances of causing a secondary neural injury diminish. And with that, going along the bone, go to the area which is your target area finally. Most of the revision surgeries, if they are not related just to screw corrections, would need you to lead your way up to the disc. So go along the undersurface or the inner surface of that cartilaginous joint which you are sort of going through. If you're planning a T-lift, get the superior articular process out, go along and go into the disc from a virgin area and enter that disc. Don't try to plunge into scar tissue and get a residual or a recurrent disc. Go into the normal area and start working from there. These are small tips that you will actually learn as you go through, and go as lateral in these revision surgeries, especially open. Identify the transverse processes. Try and conserve as much bone. Always consent the patient for bone grafting. Keep bone substitutes ready on table. If affording, even look at bone morphogenic protein. You can use BMP in the intertransverse area. Avoid using it in the interbody area. So these are small tips which I would like to give based on what I've learned over the last many years.
Thank you so much, sir. I may hand over the proceedings to Ram sir for the vote of thanks.
Thank you very much, guys. Thank you very much, Dr. Samir Ruparal, Dr. Ankit Patel, Dr. Sai Jyot Raut, and Dr. Shreel Koirala. We thank Integrace and the entire team who have hosted us. It's been a pleasure looking at Bounce Back, and it keeps us actively involved. And we enjoy these discussions where it's more like a group of surgeons, a team discussing their problems and openly discussing the pros, cons, ifs, and buts. As much as we may have tried to help our colleagues, if in any place we have erred, please do excuse us and give us your feedback. We are all learning. none of us believe that we know it all. Because I go back to what I presented 25 years back, which said good results come from experience, experience comes from bad results. So if I speak today, let me share that I probably have far worse results than most of you younger people, but I can say that I've gone through it and I've come here. And I hope that none of you go through it the way I did, and you can learn from my mistakes. So thank you very much. And thank you, Integrace, for having us. Thanks a lot.
Thank you, sir. Thank you so much. On behalf of all the delegates and Integrace team also, I would like to thank you all for this superb discussion that we had. A lot of knowledge enriching and intellectually stimulating discussions and the case presentations. Superb evening it has been. And I'm sure that just like us, all the delegates will also be looking forward to join you for the next session. So, sir, thank you so much, Dr. Ram, sir, and all my esteemed speakers here, Dr. Sameer, Dr. Sheel, Dr. Ankit, Dr. Saijot. Thank you so much. Thanks a lot and have a wonderful evening. Thank you.
Thank you, Doctor. Thank you, Dr. Ram, and all the other faculty.